Good morning, everybody. First, I would like to thank the Biochemistry Department and Chalan Madam for giving me the opportunity, and I'm thrilled that I'm talking in MLT because AM will be my alma mater. I've done my MBBS and MD here, and my admission here was years before you were born. I took my MBBS admission here in 1979. Okay, so you will be wondering what a clinician is doing here at this workshop. But what I would do is try to give you a series of cases where we see how our existence and our survival is it's symbiotic. It's dependent on each other. There's been an explosive growth of investigations available. We have a panel of costly tests created for various diseases, organ systems. You have thyroid profile, liver profile, diagnostic profile, and full body profile. And it's now become a fashion to do that. I've got a lot of people coming and eating my head. And I mean, full body checkup. And these are the people who fall into the trap of those towels who they don't understand that it's not the full body profile. त्याच्यामध्ये ते ना युजलेस 50 ट्रेस एलिमेंट्सचे अनालिसिस करतात त्याचा अजूनपर्यंत मला सिग्निफिकन्स कळलेलं नाहीये इन नॉर्मल वे एक्सेप्ट इफ यू हॅव साइन्स ऑफ टॉक्सिसिटी. So there is indication to ask for multiple laboratory tests that are offered, not defined or justified. And this actually comes from the practice of defensive medicine, which is developed and propagated by the developed countries, often dictated by their insurance companies. Another thing is, somebody does 100 tests and out of range, most of the laboratories give, and this out of range is marked in gold or red. And even of not some platelet fraction, these type of platelet, I just see the platelet count. So platelet ka niche और some 5 automated parameters रहते हैं. And then something abnormal there adds confusion, fear in the minds of citizens. So are the tests given more importance than the patient's clinical presentation? The profile of the patient fades into oblivion and the tests are dominating the scene. So what you need is maintain a good correlation between the clinical spectrum and the laboratory test is the need of the hour. You have to strike the right balance, and that needs a sound clinical judgment and good laboratory support, of course, is most essential. So I will start with the story of an HLA B27 positive medical student, followed by a series of cases to highlight our mutual coexistence point. This was my own nephew. My sister is second in Jalgaon. He had just taken, I had come to KEM in 2009 and he had got admission to SAM. And actually I came to know the history later, presented with mild peripheral arthritis following fever with throat infection. So as a first year resident, 99% of the times you are in the ward, every time he used to do the EMS duty, he used to get sick and develop an upper respiratory infection. And during one such episode, he had peripheral arthritis. And last episode, he had a history of low backache. He self-tested for HLA B27 and without showing anybody, he came positive. So I received a phone call from my GJ and and he rang me up. He started crying. एच बोलून रडायला लागला तरी तुमच्या मनात येतो काय HIV आहे का त्याचा हा टेस्ट पॉझिटिव्ह आला. So I said, okay, let me talk to him. So then I came to know that I told him this is probably a reactive arthritis. And see, HLA B27, it was the first test to be associated with an immunological disease way back in 1972. But does HLA B27 stand only for angstrom? No. More than 100 disease associations, especially systemic diseases with specific ocular manifestations, your uveitis, iridocyclitis, And other associations apart from reactive arthritis is Behçet's disease, inflammatory bowel disease, psoriatic arthritis. So these are all are the conditions which are RA factor negative. So they fall under the umbrella of seronegative spondyloarthritis. So what is the positive? If you and me do this test, there is a 2 to 8% chance that we may be positive. So in general population, 1.4 to 8% depending upon the race. The positivity rate in Axpont is around 90 to 95% in the white population, about 50 to 70% in the black population. And the positive rate in reactive arthritis is 50%. So again, HLA positive, I am HLA B27 positive on दगडावर धोका up to काहीच फायदा नाही. You have to see the clinical setting. So we did a rheumatology consultation. The diagnosis was reactive arthritis precipitated by an upper respiratory tract infection. He settled with symptomatic treatment. The only counseling I gave him was way back in 2009, wear a mask when you sit in the EMS so that you don't catch frequent respiratory infections and treat them properly. I followed him up now for the past 13 years. I mean, I have been regular contact with him. There is no recurrence of the arthritis, and now he is a successful practicing gastroenterologist in general. Going back to 1998, my own father, he was 70, type 2 diabetes, and developed a perineal abscess. You can see sugars 540, the creat came 3.1. He was ketones 3 plus positive, so he was in a frank diabetic ketoacidosis. He had with sepsis because the WBC count was 22,800, toxic granules 88% polymorph. So you know that he has got sepsis syndrome. What was worrying me was the creat of 3.1. So, diabetic nephropathy and renal failure or acute, whether there was a background, because I don't think it was done in the past 2 years. So whether he is a pre-existing AKI on diabetic nephropathy, and of course he had a perineal abscess. He was refused surgery in a big private hospital in Thane. I will not name it. They told me to Cyanco linkage. He's a high risk case for anesthesia. On checking the reports, I found that the serum creatinine was done by the old-time alkaline pigment method. And I just remembered reading somewhere in the literature that if you are having ketoacidosis, then the plasma ketones can give a false positive test for creatinine. So they may be measured as creatinine and causing the creatinine to go high. So repeating it on an autoanalyzer, it came out to 1.2. So I was relieved that he does not have renal failure. He was successfully operated, he was controlled, and he was discharged 3 weeks later. This is case 3, an 18-year-old male with acute febrile illness. So in monsoons, and now we have fevers round the clock peaking, and now monsoon is going on since October. So you will have fever cases coming till November and or December. So the routine setting, fever, your CBC showing a low platelet count. So platelet count was shown as 40,000, clumps positive. He was then NS1 antigen positive. So the diagnosis was dengue thrombocytopenia. And my patient showed me this report and told me that त्याला 4 platelet delay. So I was horrified. Why? Does 40,000 platelet count need a platelet transfusion? No. Platelets are to be transfused if the counts are less than 10,000 or he has evidence of bleeding. So suppose I have a patient who has a gastric ulcer, he gets dengue, and he's got bleeding with a platelet count of 50,000 also, I'll give him platelets to take it above 80,000 and do an endoscopy to see what the cause of bleeding is. The cost to the patient, of course, is an issue because then in private setup, the patient's other relatives try to get fees. And blood collected in a fluoride or an oxalate bulb causes clumping of platelets and leads to falsely low platelet count. So for CBC, blood should always be collected only in a EVP level. Now this was a case about 3-4 months back. This was a 16-year-old boy. He was brought to the EMS of LTFE hospital 6 hours after consumption of a blue-colored liquid, very herbicide, following a scolding from his mother over studies. So just see the futility of it. I already अभ्यास करत नाही आणि काहीतरी ही आहे. Now on he developed, and after that I think he didn't tell, or the parents thought it is a herbicide and this guy might left. Over 6 hours he developed a severe abdominal pain and vomiting. When he came to our EMS, he had a severe tachycardia, a pulse of 170. BP was maintained, he was tachypneic, respiratory rate of 28. His saturation was maintained, 99% from 2 air. The oral glucose was normal, there was no ulceration or it was an injury. He was drowsy, arousable, moving all 4 limbs. Systemic examination was normal. The ABG revealed a severe metabolic acidosis with hyperkalemia. And if you see the platelet counts are 219,000, but the renal function test revealed a Fiat of 4.5. So 6 hours of consumption of the herbicide, the creatinine is already 4.5. The serum cholinesterase level was normal, so this is not a routine organophosphorus poison. The ECG was showing sinus tachycardia. And the V1 to V6 was showing a QS complex, suggesting that probably there is a severe myocardial infarction or a myocarditis. Now, he came at night. The patient was shifted to MICU. Within 2 hours of admission, he went into cardiac arrest. He was given CPCM, put on ventilator. He died 3 hours later. Now, what are the toxins which cause severe metabolic acidosis? Apart from your salicylate and your toxic alcohols, there is one herbicide called Paraquat. So, how do you confirm Paraquat poisoning? There is a simple biochemical test. So, we contacted him. He came at 12 o'clock at night, died by morning 6 o'clock. There was some all reports were coming. So I saw that he's come at night while going to sleep at around 12:30, woke up at 7 o'clock, he was already dead. But then immediately we rang up Dr. Trupti, who was another professor looking after MICU, rang up the MICU and told the residents to preserve his urine sample to confirm. And we send it to our biochemistry laboratory. There's a simple test that 10 ml of the urine sample with 2 ml of freshly prepared 1% sodium dithionite and 1 normal sodium hydroxide is added and mixed well. If the urine sample turns blue or green, it indicates presence of paraquat in the urine sample. If it turns black, it indicates a very high concentration. In our case, blue color developed immediately after adding 1% alkaline sodium dithionate, which then turned black, confirming the severe paraquat poisoning. So that is the urine on the left and on the right paraquat. Now, what is the importance of knowing this? See, the lab has helped us diagnose this poisoning. Paraquat is a rapidly acting herbicide, which is relatively inexpensive. 25-50 रुपये में आता है. Extremely high case fatality rate. Up till now, I have had about 6 paraquats in the last 3 years. All have died. It's a corrosive. And apart from that, it undergoes redox cycling and produces superoxide ions. So these damage multiple organ systems like lungs, heart, kidneys, and liver, and over a couple of days can lead to multi-organ failure. Now, knowing this is important because management is totally different. See, what happens is, EMS मध्ये गेलो काय झालं तो फवारणीचं औषध पियायला कीटकनाशक पियायला तर रिलेटेड I mean you can't rely. They say that T20 piyaila for the lay people every insecticide is T20, but it is not like that. The management of paraquat is totally different because atropine or pyridoxine which we use in insecticide poisoning is not useful. The management is entirely supportive. Now, in T20 poisoning, somebody comes gasping, we intubate them, put him on ventilator, give him 100% FiO2 initially. Paraquat poisoning, if you give them 100% FiO2, that generates more superoxide ions and there is more damage, especially to the lung tissue. So oxygen therapy is not beneficial. In fact, invasive ventilation hastens the mortality. Patients have shock, hypoxia, metabolic acidosis. This is the term of a typical paraquat poisoning. You need to give them small amounts of dexamethasone, some antioxidants, and oxygen therapy is a very difficult proposition. You try to give the non-invasive ventilation and avoid invasive ventilation. The alveolar cell membrane is massively damaged by the reactive oxygen species. They develop progressive pulmonary fibrosis and finally die of lung failure. 15 days later, we had another patient. Now, where do you do this sodium dithionite test? All herbicide poisoning, all pesticide poisons where the actual poison is not confirmed regionally by the treating physician. Now, what we do is ask the relative to make poison घेऊन आला का? नाही डब्बा घरी आहे. काय WhatsApp video call करा आम्हाला बघून देतो डब्बा काय आहे ते. Now, so if it is not confirmed, then do this test. Then it's done in so-called insecticide poisonings where cholinesterase levels are normal because normally without organophosphorus, the cholinesterase levels are low. Also indicated in pesticide poisoning with rapid deterioration and multi-organ involvement. So we are always behind our biochemistry laboratory whenever such a patient comes, and they are very cooperative. They have this freshly prepared sodium dithionite on hand. So 15 days after this, we had a 36-year-old farmer from Dahanu who ingested, he said herbicide. We confirmed it is paraquat because he had taken it because of bad loans and crop failure. He had on admission, he had mild hypoxia, but he had a high creatinine. We had bedside dialysis in that MISU, so we gave him dialysis. He was fully conscious. He had realized his mistake. He said, "Sir, I want to leave. Lahan bola hai ghari." For 2 weeks, he had myocarditis leading minor drops. For 2 weeks, that settled. In the 3rd week, the hypoxia started worsening. And slowly he needed NIH. In 4th week, he went on totally white lungs because he had developed pulmonary fibrosis. He needed invasive ventilation and then knew that invasive ventilation, and that's what happened. He developed pancytopenia and he died on week 31 of admission. So this is how a simple biochemical test helps us, and maybe we do whatever best we can do. And coming to case 5, this is a 16-year-old diabetic lady on all these drugs. Her fasting sugar was 126, post-blood was 256. So, PFDS is uncontrolled. Would you increase the morning dose of antidiabetic drugs? You will feel tempted to. The post-lunch is uncontrolled. But if you take her history was she had waited in the queue for fasting blood collection. She had not taken the morning tablets. Now was the blood घेतलं, most of the labs tell the patients की आता घरी जा जेवा आणि या. Because for the laboratory they want to finish off their work by 2 o'clock. I am being very frank. So most of the time, the patients go home, tablet giving time. 10 वाजता काहीतरी खाताय, पारायला लॅबला जातात, they give them blood. And the post lunch is actually the 12 o'clock sample done without any medicines. Now, if you see the glimepiride metformin, all the glimepiride has its peak action about 4 to 6 hours later. Even mechanism of action on metformin, it retards the intestinal glucose absorption apart from suppressing the hepatic glycogen production. So actually you need a blood sugar done 2 hours after lunch when he's had his full dose of morning or pre-lunch tablets. So I instructed the patient to you directly wake up in the morning, take your routine tablets, have a breakfast, have lunch at 12:30 and go to the lab at 2:30 and give a PLBS. That PLBS came at 168. So there is no need to increase the dose of the medicines. HbA1c is gaining popularity now. Now, a lot of time, patients, suppose you have an airline pilot who's got uncontrolled blood sugar and has an infected medical fitness test. He may drink some neem juice, Parel juice, or they just take 10 units of acute insulin and come to you and the sugars are normal. But glycosylated hemoglobin does not lie. Because it is the average of your blood sugar controls over the past 3 months. Also, other way around. Somebody has gone for a food binge, some wedding, and he's eaten a lot of simple food previous day. The next day the sugars may come high. While this overall the blood sugar was good control. So you do the HbA1c, the goal is around 7% in diabetics. Normal range in non-diabetics is up to 5.8%. The only limitation in HbA1c is it's good for follow-up, but you can't use it for diagnosis because it reflects more the fasting blood sugar and not the postprandial. And lot of pre-diabetics have, say, as we age, we may develop pre-diabetes where our fasting may be 100, 110, but our post-lunch on a full meal may be 190, 200. And HbA1c reflects more of the fasting blood sugar, so we may miss the pre-diabetes. Now I'll turn my attention to all the jhamela which went along in COVID. For this case 6 is unfortunately my own cousin's wife. I received a phone call during the first wave sometime in August, the week of the first wave of COVID epidemic. And she rang me up. She said, Nitin, मला मलेरियाच्या गोळ्या सांग ना जरा. मलेरियाच्या गोळ्या पाहिजे नाही मला ना 8 दिवस ताप आहे अंगात आणि माझं मलेरिया टेस्ट पॉझिटिव्ह आहे. माझी कोविड टेस्ट नेगेटिव्ह आहे. Now, I am very careful that people demand such treatment. So I told her, see, 8 days of other कसं आहे ना, अजून असतो. People will always suffer from that. I said, nothing doing. You show an NG physician to Badlapur, Thana, anywhere. I am there in Sion. You want to come to Sion, you come to Sion, I'll admit you. So she told me, my COVID test is done, it is negative, my malaria test is positive. She came at around 11 o'clock to EMS. I was horrified that her saturation was just 55%. And her rapid antigen test in EMS itself was positive. She needed 15 liters of oxygen on admission, NIV within the next 48 hours, and electric ventilation terminally, and she expired after 2 weeks. So, on checking her reports, in Badlapur, the CRP test was done for COVID, not the COVID test. And the slight antigen test was positive for malaria. So in the recent COVID epidemic, pandemic, CRP, D-dimer, LDH, and serum ferritin were often wrongly used as diagnostic tests for COVID-19. And the people used to be all students of WhatsApp universities. And they used to read about them. And then I used to get a lot of phone calls of relatives trying to monitor the CRP level, crying if the CRP increasing. They say sometimes they are on ventilator and then they are fighting that the ventilator CRP कमी आला तरी पण ती कशी मेली. That sort of argument we had. No, you have to understand that these tests are just markers of the severity of inflammation and serve as best to diagnose the cytokine storm. Also, they help us to make therapeutic decision of starting dexamethasone, which was the only approved treatment for COVID-19 initially, and to follow-up of patients. I mean, roughly every 4 or 5 days, you see whether the inflammatory status is settling. Using such tests for diagnosis of COVID-19 is unjustified. And then came tocilizumab, and then came the test of interleukin 6 levels, and that again added to the confusion. Now, how that COVID-19 diagnosis was entirely on a nasal road swags. Now, remember the rapid antigen test giving the result in 15 minutes, the sensitivity is only 30 to 35%, the specificity is more than 99%. So, only 30-35% are positive on that. The RT-PCR takes 24 to 48 hours for report. The sensitivity is better at 70%. Specificity, of course, being a PCR-based test is 100%. CB-NAT and TrueNAT are cartridge-based tests, again, with a much improved sensitivity of around 90%. But what all these tells us is, if you are clinically fitting in the COVID, the patient is breathless. I've had some of my own HODs driving in to 7 Hills Hospital hypoxic. I will not name them. HOD of 2 departments, lucky to survive. COVID test done on some formal ward kit negative, but they were breathless. Finally, wife is screaming at them, saturation 90% झाला, आता तरी hospital ला. So you have to understand the clinical spectrum. Saturation falling. My own another cousin sister was admitted in Pune. Husband came positive, she came positive. She was around 62. They had facility of hotel मध्ये ठेवले मला. Some private setup. And it was the Ayurvedic doctor comes and monitors. And then next day she told me, I come here. She didn't know. She was a manager in Canada back then, retired. But the saturation 90-92 level. But what people feel is, 100 join the 100 पैकी 100 नाही मिळाले काय झालं 90 मार्क्स मिळाले तर चांगलं आहे. तर ती कॉमर्स ग्रॅज्युएट तिथं तसं 90-92 saturation आहे. तुला अगर 90-92 means your 25-30% of the lung is involved. It took me one full Sunday to insist on that private setup to do her HRCT. HRCT, the CT score was more than 70% lung involvement. She needed, she then was shifted to an ICU, was in the ICU for 15 days, lucky not to go on ventilator. I screamed at them to start dexamethasone, start remdesivir. She came. So you have to clinically look at what the patient has. Many times in science, we used to have at night because of the load. We used to have 45 minutes Zoom sessions at night where all the department faculty used to give input on the serious patients. That also reduced the mortality. And quite a few times we had patients where the CT is suggestive of COVID. The test is not, but we have gone ahead with remdesivir and dexamethasone and then tried to do the antibodies to see whether the COVID antibodies are coming positive, and then IgM antibody has come positive and patient has responded to it. So another was CT value. Pura Janta was obsessed with CT value. Now, what is the CT value? The cycle threshold value is an indication of the severity and infectivity of infection, with a lower value corresponding to higher infectivity and vice versa. The cutoff was around 30 to 35. So don't break your head over it. What it means that if your CT value is 50 and you are coughing, lot of patients, 90% of the patients around you will get infected. Your CT value is 28, 30, even if you cough, around you 20% they get infected, nothing beyond that. Now, this one life-saving drug, which is interleukin-6 receptor inhibitor. This is a novel monoclonal antibody, tocilizumab. And this did prove effective in patients of COVID, and we started declaring IL-6 levels. But see, what you have to understand is high IL-6 levels tocilizumab indicated. There were some clinicians who kept on asking the laboratories to do IL-6 levels daily. So this is a IL-6 receptor inhibitor. So if you give the drug and the receptor is blocked, the IL-6 levels, the body will produce more IL-6. So the IL-6 levels are keep on increasing. Next day, there is to see high IL-6 level, give one more tocilizumab. That tocilizumab 44,000 there. But then there was black marketing. But the market was the bull number. So all these sort of bizarre things have happened. Tocilizumab, you don't have to repeat. One day is enough. It's either it helps or it doesn't help. But the IL-6 level, I think, will be double. They get tocilizumab. Then I have seen people receiving 4 tocilizumab at the same time. Now, high D-dimer, how did it help us? In the second wave, we found that a lot of people were dying of thromboembolic complications, brain strokes, pulmonary embolism, heart attacks. And then high D-dimer is the predictor of the thromboembolic events. So, heparin, which was another justified treatment in COVID, and severe D-dimer levels, which we did, was an indicator how long to give the anticoagulation. Many times, madam, patients have gone home and died after 2 weeks or 4 weeks. So then we started doing a D-dimer on discharge, and if it is high, we started giving them oral anticoagulants for the next 1 to 3 months. We have oral rivaroxaban and apixaban, which you can safely give without PPI and monitoring. Other inflammatory markers like serum ferritin again are used for monitoring the severity of it. So that is the COVID controversy. Next few cases, now this is a 17-year-old college student. One neighbor of one of my relatives, so my aunt told me I was going to HLA B27, Jaundice, and nothing is working. Now I saw her reports predominantly slight bilirubin of 3.3, but predominantly indirect hyperbilirubinemia. The liver enzymes just at the upper level of normal. So this is not a viral hepatitis. This is not a toxic hepatitis. The viral markers were negative. Her CBC showed an MCV almost of 119 with hypersegmented neutrophils. So what is the diagnosis? This was she was a pure vegetarian. So this is actually a megaloblastic anemia. And in B12 deficiency megaloblastic anemia, the RBC precursors have a difficulty in maturation, and they die within the bone marrow, and their destruction causes increase in indirect bilirubin. She was the openest Brahman, so pure vegetarian diet. So you just need to give B12, and that resolves the jaundice. Now these are the two cases. The 33-year-old diabetic male was a corporator from Sion Hospital and he's still quite very active in politics. The above male was my neighbor. Both had jaundice and they were diabetics, PNMA subcontrol, and both of them had direct hyperbilirubinemia. If you see in both of them, the direct is more than 50% of the total bilirubin, the liver enzyme slightly high. Now, if a diabetic patient has such a report, check the drugs which he is taking. Both patients were that time on dimethylamine, which is a sulfonylurea, and sulfonylurea is known to cause cholestatic jaundice. So they might go on trying that corporator for 2 months was taking some Ayurvedic kada and all. That will not help. The simple treatment is stop dimethylamine. Give them metformin, they respond. Then again, your fever and the way people run after the doctor, they run after the labs, they fight with the lab people for not giving तुमचे laboratory बरोबर नाही, तुमचे test positive येत नाही. Now, see, so we'll see two cases. This was a 22-year-old male with fever for 4 days. And his Widal was Salmonella typhi H180 positive, O was negative. He was diagnosed as typhoid, started on 30 antibiotics. Now, what are the pitfalls of the Widal test? It actually takes at least 1 week of fever to become positive. Only the core titer is specific, and you need a rising, at least a 1 in 80 with a rising titer or a 1 in 160 titer. O is the somatic antigen of the Salmonella. H is a non-specific flagellar antigen which is shared by multiple or gram-negative zoo in the intestine. So H is non-specific. Then there is also something called an anamnestic reaction where after typhoid for the next 6 months to a year, any fever will cause the H titer to rise and to become positive. Hence, if you want to diagnose typhoid in the first week of fever, a blood culture or clot culture should be used. Then serum electrolytes. During one post-emergency, I had 7 to 8 patients coming with potassium values between 7 to 10. And 7 is not compatible with life. So when I inquired, I found out that there was one new intern. He was God's angel. Then he felt that 20 number maybe is causing pain. So that there is no pain while blood collection, we use 22 and 23 number needles that call non-hemolysis. So because the resident, my resident immediately said, "I biochemistry laboratory extraction, allow potassium there." Nahi. Problem is not biochemistry laboratory. They have written the sample. Like Garo, tula samjhana paहिले they written the photo file and माझ्या support. And it says, "Sir, I used 23 number." So this is the don't blame the laboratory. So we have to understand that hemolysis during blood collection is the most frequent cause of hyperkalemia. Okay, RA positive. This is the 30-year-old female RA test positive. It's severe joint pain. Now, RA is positive in 50% of healthy persons. The frequency increases with age, can go up to 10 to 20% in people more than 65 years. So, RA is a clinical diagnosis of symmetrical body arthritis, more than 5 joint involvement, typical small joint involvement of the hand. And for false positive, RA test is found in all these list of conditions. It can even be transiently positive after vaccination. So, if you have fever followed by joint pains, and it's not classically fitting in RA, also look for chikungunya. Because we have a lot of reactive arthritis and chikungunya keeps on occurring every 3 to 4 years. You go to India, Maharashtra, everywhere. Almost 20 to 50% of the village population is affected, and you just need to do an IgM chikungunya antibody for the diagnosis. Even the ANM test is positive, of course, a marker of SLE. But 15% of healthy individuals can have a positive ANM test without an autoimmune disease. So presence of multiple autoantibodies without clinical symptoms. See, suppose you have some company having a tie-up, and they tell that we will do the autoimmune profile, and they do the autoimmune profile of 100 of us. Each one of us may have 1 or 2 positive. So it's again the title of the test and the pattern of immunofluorescence, which is important to be interpreted with the clinical situations. And last 2 cases, this was again some relative 82-year-old male, fracture-like fever, hip replacement done, the pre-op serum creatinine 1.2 mg/%, received taxane 1 gram 8 RMB, Genta 80 mg 8 RMB. So known the doses. And was operated in my friend's hospital. So 10 days later, that orthopedic person called me, Karnik, the patient was drowsy. So on day 10, I saw him, the urine output was 1.5 liters per day. But I told him that he was very high dose of antibiotics. The patient has renal failure. The moment I said patient clinically used to have renal failure and he is drowsy because of uremic encephalopathy, that orthopedic person took it as a personal insult. My friend, the surgeon. So he started shouting at me, "Tu khai kya bolti? The urine output ko 1.5 liter aaye." Therefore, I am saying this is renal failure. Why? Because aminoglycoside induced renal failure is a non-oligonucleotide renal failure because it affects the tubules and the tubules the function is to concentrate the urine. So if you have 2 liters urine output that in the summer of May, when the input is hardly 1.5 liters, that indicates a tubular dysfunction. So he was very upset. I said, "No, you do the serum creatinine, you are horror." The value of creatinine, which was 1.2, KMS 10.6. This is a true life story. He needed dialysis. That man expired after 48 hours. So what that tells us is as we age, the concept of creatinine clearance is important. And it's easy to calculate. The formula is 140 minus age into E body in kgs upon 70 plasma creatinine. So if you see in him, his age was 82, the body weight was 72. So this creatinine clearance actually was only 48.3 against a normal of 100 to 120. So he should have received half the doses of these drugs. So maximum he should have received 18 milligram OD and cifotaxin maybe 1 gram BD. That would have been enough for him. Fortunately, most of the labs where you are working now take the pains to give the estimated EGFR reports. And then most of all the anemia and accredited labs, they are giving the EGFR reports. So at least, it tells us that because a creatinine of 1 or 1.2 at the age of 80 doesn't mean that EGFR is 100. Because of age, the kidney function itself reduces. So giving the EGFR values helps in preserving the kidneys, and the clinician always has to adjust the dose of antibiotics, especially in elderly population. Then, lastly, diagnosis in fevers. When our fever and the relatives get very agitated, हमको पता हो मलेरिया है कि डेंगू है कि लेप्टो है, अरे टेस्ट लैब में सब टेस्ट किया सब नेगेटिव आया और बाद में प्लेटलेट फॉल हो गया तो ये क्या संतु लैब है. This is what goes on. So what you have to understand this first for malaria. When you have a liger, all the parasiticides and herbicides get lysed. So if the smear is done just after the liger, the MD is going to come negative. Probably the rapid antigen test, which is a slide test, may come positive. So if you know when the liger is coming for malaria, you have to time the blood smear just before the predicted onset of the next liger. Then of course, though the thick and thin blood films are the gold standard, the rapid antigen tests, which will use the plasmodium falciparum of specific histidine-rich protein 2 or the LDH antigens, are useful. But they can detect the live as well as the HLP2 detects even the antigen of dead parasites. So they are useful if you've done the blood collection after the liger. They are helpful in partially treated cases or those with low parasitomias or when microscopy gives negative result, but you cannot monitor the parasite clearance or quantify the parasite load. Then every monsoon sees a spurt of fever cases. And see what happens is because of the pressure of the relatives. What I tell the patients is if you have fever, just take paracetamol, you have throat infection, take azithromycin, should better take. 3 दिन के बाद you do this test. Why? Because they take a minimum of 3 days for the test to come positive. And the pressure on us is on 24 hours everybody wants. So I tell them ब्रह्मदेव के पास गया तो फिर ब्रह्मदेव diagnosis नहीं देगा. 3 दिन चुप बैठो घर पे. Clinically, you see saturation with maintained throat infection is a simple antibiotic. And then repeating this test multiple times adds to the cost and anxiety. The timing of this test is important. Then NS1 antigen PCR will come positive between 2 to 5 days. The IgM antibody may take even 1 week to come positive. Similarly, leptomat and PCR is positive after day 3 and lepto IgM antibody after 7 days. So you have to understand that the timing of blood collection is important in fewer cases. Now this is the last interesting case. 85-year-old female, bedridden since 10 years, presented with hemiplegia. She had a high BP, sleepy pupil, and macular infarct. But interestingly, on the chest X-ray, can you see the wall of the bronchus? Can you see the calcification there? Can you see the trachea calcified? This is the tracheal division. This is the left bronchus. This wall was calcified. This is the wall of the bronchus. So I was interested, okay, why is there metastatic calcification? I mean, this is a sign of metastatic calcification of the tracheobronchial wall. And when does metastatic calcification occur? When the calcium product, calcium into phosphorus product exceeds 55. Normally the product is around 40. So let us see whether this fact is supported by the laboratory investigations. She had a slightly high serum creatinine, but see, her calcium was 8.4, phosphorus was almost 7. The product was 57.96. So the product is more than 55. So the laboratory has confirmed my clinical suspicion. The ultrasound of the kidney showed bilaterally shrunken kidneys. So I suspected a secondary hyperparathyroidism due to chronic kidney disease. We did a PTH levels which were confirmed as high. Okay, so it's always that the clinician, whatever we suspect, we need a good laboratory and then the diagnosis is confirmed. Some common errors are blood sampling, especially for grouping cross-match samples, because if you don't write the full name or don't put the upon mismatch, transfusions can happen. So to conclude, judicious use of available investigations, interpret the lab results wisely. The clinical condition of the patient is the primary guide and laboratory data are supported. Always give due respect to the age for user adjustment, especially for antibiotics. And we need to work in cohesion so that the patient's health is maintained. Thank you very much for your attention.